We are here with the 7th episode of our series on controversies and consensus in orthopedics, what we need to know. This series is being conducted bi-monthly every Wednesday evening with a new hot topic in each subspecialty of orthopedics under the chairmanship of Dr. MOHANTY and Secretary Dr. PHADNIS, Dr. SWAPNIL, KENY, and myself, Dr. DEEPAK GAUTAM. Dr. MOHANTY is the professor and unit head of Department of Orthopaedics at SWAPNIL Medical College and KENY Hospital, Mumbai. He is also an honorary consultant at Jaslok, Nanavati and Associates Hospital. He is the past president of Indian Arthroplasty Association and Bombay Orthopaedic Society. He is a great academician and researcher. He is the education chair of Indian Society of Hip and Knee Surgeons, reviewer of famous journals BJJ, COT, and our own Indian Journal of Orthopaedics. Today is the day of controversies in robotic joint replacement. We have our eminent speakers, Dr. GURAVA Reddy from Hyderabad and Dr. Bharat MODY from Gujarat, and moderators, Dr. RAJESH MALOTRA from New Delhi and Dr. INDRAJIT SARDAR from Kolkata. I would now like to call upon Dr. MOHANTY to introduce our speaker and the moderators and proceed with the session. All to you, sir.
Good evening, dear friends. Welcome to yet another controversies and consensus in orthopedics. Could you just allow me to share my screen? Poonam? Okay. So today it is entirely devoted for the robot, which is a hot topic now, and let us discuss and listen from the stalwarts on the robotic surgery. And we have four eminent persons today on our podium. And first, let me introduce Professor Rajesh Malhotra, who is going to be the moderator for this session. Professor Malhotra is the clinical leader. He's a true die-hard Delhi. He's undergraduate, postgraduate, and the whole life was spent in AMS New Delhi until June 2023. And he was the association, and he has won many awards, including the prestigious BC Roy National Award for Eminent Medical Teacher. And he was a Johnson Johnson Revision and Rope Fellow of the IOA, Senior Traveling Fellow of IOS UK. And he has done fellowship in advanced trauma in Germany. He was a Ranawat Orthopedic Center Fellow, ROC Fellow, and convener for Orthopedic Initiative of Indian Society of Bone Mineral Research, Secretary of Regional Fragility Fracture Network India, member of Research Committee of COT. And he has almost 900 publications, and he has given almost 800 lectures to his credit, and he has been reviewer of many journals. I don't know how he finds time to review. I am unable to review 4 journals, in my lifetime. Thank you, Dr. Malhotra, and welcome to this show. We have Dr. INDRAJIT Sardar. INDRAJIT Da is a senior consultant orthopedic surgeon from Nightingale Hospital, Kolkata. He is the past president of Indian Arthroplasty Association and past secretary and president of West Bengal Orthopaedic Association. And at present, he is the first vice president of Indian Society of Hip and Knee Surgeons, and going to take over as the president next year. He is the organizing secretary of Beautiful IOACON, which was held in 2019 at Kolkata. Organizing secretary of East 2013, president organizing committee Milestone, and he has more than 100 presentations in the state, national, and international meetings. He has presented a white paper at IOA in 2008 at Bangalore. He was the first leader of IPGMR Kolkata, an Inspiring Orthopedician of India Award, Chikitsa Bharat West Bengal, and Lifetime Achievement Award 2022 of Medical College Students Association. Thank you, INDRAJIT Da, joining today, and welcome to the our 7th episode of Controversy and Consensus in Orthopedics. Now, we have 2 eminent speakers today, and Dr. GURAVA Reddy, I think is not unknown to any of us. Is the chairman of Sunshine Bone and Joint Institute and chief consultant joint replacement surgeon and MD of Sunshine Hospitals, Hyderabad. And as you know, he's the founder and MD of Sunshine Hospitals, and he's immediate past president of Indian Society of Hip and Knee Surgeons, and he was a founder member of East as well. He has established the Sunshine Ortho Robotics, a designated global center of excellence for robot-assisted joint replacement surgery, and many fellows. Every year I think 12 to 14 fellows they get trained under Dr. GURAVA Reddy at Hyderabad. And he's the first to acquire the fourth generation of Striker Mako Robo in India, and hence is a proponent of Robo, and we'll listen from him what Robo is offering to us. And he is international committee member of AKASH and editorial board in the Orthoplasty Today, and founder member of South Indian Orthoplasty Association, which offers a fellowship, as well as South Indian Orthoplasty Association has been very active in doing research, especially in Indian scenario. Thank you, GURAVA, joining us today, and thank you for your deliberations today, which we'll listen to you. Next, Dr. Bharat Mody. He is Director and Chief Joint Replacement at WellCare Hospital, Baroda. He founded the Center for Knee and Hip Surgery at WellCare Hospital. He is at present the President of Asia Pacific Orthoplasty Society, and he'll continue for about 2 years. He was the President of Indian Orthoplasty Association in 2015. And selected by the Governor of Gujarat as one of the nominated members of Senate body of the prestigious Maharaja Sayaji Rao University of Baroda in 2022. He was appointed Scientific Advisory Committee member of Effort Asia, appointed Chairman of Advisory Group of Bayer India for development of Geralto in India, appointed as a member of Advisory Board of Deputy Institute. He was the lead designer in the design of TKR surgery instrumentation set developed by Johnson & Johnson, especially for the Asian market. That's why Bharat Bhai is talking about the, about how manually you can do a much better knee replacement rather than a robot-assisted surgery. Appointed as a board of international panel of reviewers of JBJ's research journal in UK, and has more than 20 international published research articles until now, and authorship of many book chapters. Thank you, Bharat Bhai, for joining today, and welcome to the show. Now, without any further ado, let me hand over the proceedings to Dr. GURAVA Reddy, who will tell us that how robot is helping us in our arthroplasty surgery today. Over to Dr. GURAVA, please.
Thanks, Mohanty, and thanks all the other esteemed audience here. And it's a pleasure and privilege to be in this August gathering. And so let me share the screen. Can you see that? No? Yeah, right. Let me share the screen. Okay, desktop, share. Can you see that?
Yes, you can see it now.
Can you see the slides?
Yeah, in the form of
okay, I think
the form of a slide sort of view. Yeah.
Can you see that now?
Yes.
yes, sir.
Yeah, okay, right. Good evening, everyone. So I'm going to talk or debate with Bharat, who is a good friend of mine, about the necessity of robotics or no. I'm ready to be countered, or in a crude words, raped by Bharat, but that's a part of the game. Okay, so, right. So, today I'm confronted with the Shashi Tharoor of arthroplasty. I'll call that him. Bharat, you can see the similarity in the attire and similarity in the eloquence and the selection of English words when he speaks. So don't be fooled by his English eloquence. Sometimes he conceals his lack of knowledge in the fluence of the English. So be prepared for that, okay? And this is my esteemed Bharat Mody's hobbies: ornithology, carpentry, magic, and antique collection, and fire safety. If you see the third one, magic. So that's what he plans to do, magic. That means he will make you believe that there is something which is not there. Okay, today's agenda, I'm going to talk whether the robotic is it worth. Let me tell you, my friends, cost and worth are relative terms. Price and value addition are different. So don't get mixed up these things. The true debate here is robotics truly helping improve patient outcomes, or is it only a marketing hype? Both short-term and long-term, and most surgeons listening today would want to know that. So my agenda, our next 15 minutes, what I'm going to talk is both mostly what is wrong with the mechanical alignment, which we are doing for the last 30, 40 years. What are our options if not mechanical alignment, and how to achieve them, and short-term benefit and long-term benefits like less pain, better functional outcomes, better patient satisfaction, and reduced failure rate in registry, Australian registry in 2023, it has come out. So now you all know the paper that 1 in 5 is dissatisfied with the knee replacement. The number may not be true in Indian perspective, but if you see the literature, there are different factors. One is socio-demographic, that is age, ethnicity, living alone, body weight, BMI. And next, preoperative mental health, pain in the other joints, poor knee scores. And intraoperative is implant design, technique, component alignment, implantation methods, laxity patterns. Postoperative, stiffness, pain, poor knee function, complications, narcotic use. Of all these, only the two things, component alignment and laxity patterns, are amenable for robotic manipulation. And that's what I'm going to concentrate today. The rest of the things are not in our hands. So mechanical alignment, we have been trained. All of us are trained in England. Most of us, we have lived with that. We held INSAL in the highest esteem. And why now there's a lot of hubris around the mechanical alignment. The same goal for every knee, 90 degrees cut to mechanical axis, neutral HKA and joint level obliquity. Target is equal compartment loading, stable biomechanical construct, and long-term survival, no doubt, 94% at 15 years, 82% at 25 years. But why we got to go and debate at all? It ignores the native alignment and joint line orientation. It lengthens the lateral column. Patellofemoral retinacular tension is more. It influences subjectively reported clinical scores and prompts. So that's why we got to go and revisit that. If you see that, can intraoperative alignment change the outcomes in total knee arthroplasty? A recent paper by Veningini. And if you see here, the blue color is the kinematic alignment, no releases, and the other colors are gap balancing and measured resection. If you see the tibial compartment forces, they're almost 4 to 3 times higher compared to kinematical alignment. So don't tell me that this joint is well balanced or well pressurized on both sides. And like that, another McDessie paper in 2020, restoring the constitutional alignment with a restrictive kinematic protocol. If you see here again, the intercompartmental pressure difference is this is the mechanical alignment and this is the kinematic alignment. You can see that 3 times in 10 degrees, 90 degrees, it's 2 times. So that means pressures are invariably more intracompartmental in mechanical alignment. So that is what the loading pattern, another paper. And again, you can see native knee and calipered kinematic alignment are almost same. In other words, by digressing from the mechanical alignment and going towards kinematic alignment, we are definitely restoring the native joint pressures. And now another important landmark paper is McDessie paper. You should see that every knee is different. Should we have different targets, or we should put one joint in everyone? That's why I feel that 1 in 5 joints is unhappy. So this is a Chittaranjan Ranawat Award in 2011, I think, almost 12 years back by Bellman. So this, he said he was the first one to coin the term constitutional varus, and he assessed the normal healthy pre-arthritic knees, and he said 2/3 of the men and 17% of the women have got a varus of 3 degrees or more, and less than 5% patients have got a neutral mechanical axis. Then why we are aiming at mechanical axis? But I agree with the INSAL. In those days, there were no fancy gadgets like a robotic, or there are no fancy or highly Einstein brains like Bharat MODY in INSAL's team. That's why he managed to go for the mechanical alignment, which is easy to get it. And then the phenotype-based classifications have come. Hirschman had said 125 phenotypes, but the CPAC now, McDessie has got 9 phenotypes, which has become a landmark paper. And this is the paper, and you can see that all the 9 methods, varus, neutral, and valgus, apex distal, neutral, apex proximal, all of you must have gone through this paper. And in fact, we have published a paper in extra to this. We have published a paper, coronal plane alignment of the knee classification for knee phenotypes in Indian population. So our CPAC is mostly 1, whereas the European CPAC is 4 and 5. In fact, if you go and see the literature, you can see here, 21% of the healthy subjects have got CPAC 1 and 58% have got a CPAC 1 of arthritic knees. Compared to Japan also is the same, but whereas Europeans and America are different, only 19% is there. So in other words, there is a global variation of the different phenotypes of the knees. So you cannot put the same mechanical alignment joint in every knee which you come across. So let us say, what is the difference between the three most important alignments? I'm not going to bore you with all the alignments. You all well read by this time. Basically, end of the day, it is a personalized artificial joint, whereas the implant design, unrestricted kinematic alignment or restricted kinematic alignment or ligament isometry, all of them will play a role in this. So we set some alignment boundaries and we set some soft tissue laxity patterns, and end of the day, we go either unrestricted or native laxity, depending on our thought process and on our philosophy there. So many alignments have come: kinematic alignment, restricted kinematic alignment, and functional alignment. So you all know this here. There is no need to alignment there. So now kinematic alignment, everybody knows that there are three axes at this time: flexion extension axis of the femur, which is set green, and flexion extension axis of the patella, seen on the purple, and interrotation external axis of the tibia, yellow. All three axes are either perpendicular or parallel to the joint line. This is the basis of the kinematic alignment. And kinematic alignment, basically the argument is the native joint line obliquity and alignment are restored. It takes equal of the bone and cuts parallel to the LDFA, MPTA, and PCA, and adjusts for the cartilage wear and bone loss. Resultant soft tissue laxity is accepted. The cons are gap imbalance is possible. The IR of the femur can happen. Unrestricted extreme alignment position is going to happen. So then the restricted kinematic alignment has come. I'm sure Bharat will make a lot of jokes on this multiple alignments, but this is the truth, and this is the purpose, and this is the flavor of the argument, and this is the flavor of going forwards. Okay. And now algorithm is strictly in our followed in our hospital is, if the MPT and LTVF is less than 5 degrees, we go this way. And if it is more than 5 degrees, we'll go this way. And we'll do functional alignment or restricted kinematic alignment depending on the MTP. Now, functional alignment is basically, it's restricted but balanced. It's a Mark Pagnano and Faris Haddad from England. Both are the proponents of this. It's a balance-driven strategy, 3D planning, and restricted boundaries, and robotic assistance is a must for this. So the aim of the functional alignment is components are adjusted to balance the knee with the least compromise on the soft tissue and changes in the joint level obliquity. But the important thing is all dynamic balancing like 6 axes can be manipulated, but with restricted boundaries. So 5 concerns raised regarding personalized arthroplasty, which I'm sure Bharat will allude in his talk, is unstable biomechanical construct, recreating of native hard anatomy is impossible, role in gross deformity and bone loss, what is lax pattern is perceived as normal, where is the published evidence? I got answers for all of that. Now the critics should keep their mouth shut. The long-term survival of kinematic alignment, lovely papers have come. This is one of the papers from Dorset and Spangay, a randomized control trial, 13-year long-term survivorship, kinematic assessment alignment versus mechanical alignment. The 88 patients and the results are equally good. And again, another paper by Howell, implant survival and function, 10 years, a kinematic aligned total knee arthroplasty, 97% are doing good. So again, this is a from Mayo Clinic, Danbury's paper. He says that basically the so-called outliers, as evidenced in the Mahalakshmiwala paper, is no more valid. He says the 3 degrees outside layers also are doing very well. And in fact, Pagnano and Abdel has produced now 20 years paper, the same paper they extended. So implant survivorship doesn't have any bearing on the outliers, on the alignment. So basically, it is the balance that is very important. If you see this slide very carefully, the first one is malaligned and unbalanced. This one, whether Bharat does, or whether GURAVA does, or whether MOHANTY does, it will fail. There is no second thought about it. But the second one is mechanical alignment. Here, the excellent survivorship, no doubt, but PROMs 80% happy. Because here, their accuracy is there, but the precision is not there. But when it comes to the accuracy and precision, you want to go right into the center. That is what personalized alignment, and already survivorship is showing 13 years of survivorship, and PROMs are also very promising. And I feel that in the next 5 years or 10 years, the personalized arthroplasty will come in big way. And recreation of the native heart anatomy, again, another con point is they say, but the kinematics will be very much restored there. Now, he says, Bharat will say that robotics cannot do anything in the gross deformities and bone loss. We tend to differ with that because we ourselves published a paper, which is now coming to the mainstream, like evidence-enhanced mid-dissection workflow technique for severe varus deformity using robotic arm-assisted total knee arthroplasty. It has been published and being quoted again and again. You can see that this gross deformity in gentlemen, and we did with the robotics, the functional element, and no problems at all. So gross deformities also can be done. Okay. So now let me go to the next slide. So better outcomes. Definitely another paper has come, Haddad paper, this robotic arm assisted total knee arthroplasty with improved early recovery. And we also published a paper, the people who underwent non-robotic arthroplasty in the past, but robotics now, 9 out of 10 patients opted that robotic arthroplasty felt good and native and normal. That is the thing which they started using that nowadays. It feels normal. And now another important benefits of the peroperative technique of the robotic is the bone preparation is active stop haptics are there. So you will know where to stop and you will know that the patellar tendon will not be cut. The tibial tuberosity, the PCL will not be cut because the haptic boundaries, it will not allow the saw to go out and cut it. Even if it is your mother-in-law, even if you want to cut the ligaments, you cannot do anything like that. So that's a very wonderful advantage of this one. And now the same thing with the tibial cut, the same thing with the posterior femoral cuts. So these things, normally you cannot see what you are cutting, but here you can see them. That's a wonderful thing. Now, evidence supporting kinematic alignment over mechanical alignment, meta-analysis have come, 5 randomized control trials are there, retrospective studies are there, all of them unhesitatingly proven that kinematic alignment is as good. Now, in the coming 3 slides, my friends, this is from the recent Australian registry. If you see, this green one is the Mako robotic, and this one is a non-robotic manual. These other things are other robotics like Navio and Rosa. If you see the revision for instability, the Mako robotic is the least compared to the manual. So if you can go to the next slide, and again you can see that this green one is the Mako, and the other ones are the other robotics. And another important slide here is even the triathlon, they have taken one manual, the same implant, and one with the robotic. And the robotic triathlon is a much better survivorship than the manual triathlon. So that goes to prove that the robotics is definitely improving the outcomes of the patients and longevity. These are some of the 2 young guys who have redefined the robotics. And now for the skeptics like Bharat, please keep your mouth shut for some more time, because we are just seeing the tip of the iceberg. If you want to look into the future of arthroplasty, many more things to come. The artificial intelligence, machine learning, big data, all of these things will come into picture in the next 5 to 10 years and will give a beautiful algorithm how to take care of the joint replacement, gross deformity. When I was going through the web, I came across this WellCare Hospital virtual surgery using 3D technology. And it was the first of its kind in Gujarat, advertised. And I was stunned and stumped. What is this virtual surgery using 3D technology from a skeptic like Bharat Modi? So of course, he is there going to say a special protocol of the CT scan. He's going to do that. And his engineers are creating a virtual 3D model. And then he performs a virtual surgery. I didn't understand what is that. And then he will perform the rehearsal surgery on the 3D printed joint after such successful virtual surgery and rehearsal surgery. And now he will do the actual surgery. So I don't know exactly what this means. I don't know what is the scientific rationale. And I don't know where he is going to undermine the robotics with this so-called 3D reconstruction. I wanted to hear his ideas and thought process. So we have done a lot of alignment studies. We have published 4 or 5 papers, and we are going to do some more papers. So basically, take-home message is mechanical alignment is still the gold standard, but personalized alignment strategies might solve some of the surgeon-derived factors which needs further concerted research. Robotics is the only way to achieve these targets. I'd say that. And evidence has shown less pain, better function, better problems, including forgotten joint scores, already published, and reduced failure in Australian registry. And I'm sure the Bharat will talk about Icarus slide, that we are trying to fly too close to the sun and fail. But let me tell you, my friends, Bharat is a very, very adept technician. He is ready to learn the dancing steps from the Australian Aborigine, but he is a very timid or skeptical to take the robotic further. And he wants to go to paradise with his wife. And let me tell Bharat, please shed your clothes of hypocrisy, shed your clothes of suspended animation of your wisdom, because you are the one who always tells the difference between knowledge and wisdom. According to him, we got the knowledge, but he got the wisdom. And if you see his dressing, he is always immaculate, bespoke dress. He doesn't go to the shop and pick up the dresses. He will get them stitched up. When you take such a precautions, such a diligence in dressing yourself, why don't you give the same benefits to your patients, my friend? So I want you to be open. You got two young children who will be giving you the robotic if you don't give them the robot. So first do the robot and then tell whether the robotic is good or not. Okay. So the debates are going to be there. In fact, I was involved in debate with Bharat many a time, but let me tell you, he can give you a prophecy, he can give you a bhashan wherever you are in the world, whether you are in the high street, whether you are in the bathroom, whether you are in the bedroom. But end of the day, let me admit, he is my guru, he is my Krishna, and I take all my Bhagavad Gita lessons from him. So God bless both Bharat Modi and the robotics. Thank you.
Wonderful. So, Guru, what a beautiful presentation. What a beautiful presentation. Can I start with sharing my screen here?
And another thing before just Bharat takes over, the robotics is here not only for total knee, partial knee, total hip. That is the only way to go. If you see the hip and partial knee, you will know the efficacy and validity of the robot. And even Bharat, a skeptic like Bharat, has to agree that that is the way to go. Right. Thank you so much.
So, Guruva, for an excellent lecture and preparing the battlefield for Bharat Bhai. So let's move on to what Bharat Bhai has to tell us. Over to Bharat Bhai.
Am I audible?
Yes.
Yeah, audible and visible.
Wonderful. Yes. Okay. So first of all, I applaud Guru. And you know, Guru, you are the emperor. And I'm so happy that you mentioned things like clothing, bespoke clothing, etc. You'll see how intuitive our wavelength is as soulmates, you know, as buddies. And you will see later in my talk how I preemptively or maybe premonition incorporate that as part of my message today. Now, you gentlemen, just before I start, how do I start? Oh, how do you control this? Hello? Okay, yeah, got it. All right. So, gentlemen, before I start, I would like to point out the last few slides that Guruva offered us as scientific evidence, you know, and those were all those 3 or 4 papers that he presented. And we will reach that for further analysis and dissection. But at the present time, before we forget, I would like to bring it to your notice. All those 3 or 4 papers were talking about kinematic alignment not being inferior to mechanical alignment. Okay. Do you see how subtly the goal is being shifted? On one side, we are talking about something, God's gift to earth in terms of some superior, you know, magical methodology that has suddenly descended upon planet Earth. And yet, when we offer scientific data, it's more about trying to prove that it is not inferior to mechanical alignment. But we'll come to that in a moment. So why do I not feel the need to commence robotic TKA? Here are my declarations, gentlemen. I am not a secret Luddite. I am a Gujarati, and I still read stories by Hans Christian Andersen. All right. For those who might not know what a Luddite means, he was the guy who revolted against industrialization in the UK when the industrial age was brought in and machines were brought into the textile manufacturing. He broke, Ned Ludd was the leader. And so from then onwards, anyone who is against technology is labeled as a Luddite. I'm not a secret Luddite. In fact, I'm addicted to these gadgets, whether it be, you know, a phone or a computer or my home automation system. I'm addicted to technology. There's no way that I would say that I'm against technology. I'm a Gujarati. history has shown that Gujaratis are thoroughbred business people. They generate value. All decisions in life should be titrated to generate true value, gentlemen. And that is why you can see here that no one does business like the Gujaratis do. The proof is in the size of their wallets. And 5 out of the top 10 richest persons in India are Gujaratis. Although not a billionaire, I subscribe to the same philosophy because I am not the Maharaja of Hyderabad. I don't have the Golconda mines available to me, full of diamonds, a cart full of diamond every day. And the point is that even Shah Afzal Jah, who had these Golconda mines, eventually went bankrupt because he did not know how to titrate value in his life. And that's what these Gujaratis know how to do. So what is value? Oxford Dictionary describes value as the worth of something compared to the price paid or asked for it. And all I am going to bring home to all of us here, which Guruva rightly said that I have wisdom, he has knowledge, and I agree with him. Wisdom is in understanding what is providing value to us as surgeons, and more importantly, to the patient fraternity. Now, let us understand, when we talk about robotics, it is important to trace the history. We get lost in our enthusiasm about the technicalities of measuring and that complex chart that Guruva has now evolved at Sunshine about measuring tiny things to make the decision about how to do a particular knee replacement. But let us understand how this entire yatra started. What is the raison d'etre for robotics in TKR? Raison d'etre meaning the reason to exist. The reason to exist for robotics in TKR started with the 20% deficit in the dream for the forgotten knee. Belief that if we bring measurable accuracy to alignment and bone cuts, and it will help achieve this dream, is the underlying belief. Let us examine whether this belief is actually turning into reality or not. This the quest for the Holy Grail to eliminate the 20% forgotten knee. And understand, for those who might not understand what a forgotten knee is, they ask questions to a cohort of patients between hip replacement and knee replacement. Those patients who had undergone hip replacement, a large proportion, almost all of them, said that after some time we forget the fact that we had a hip replacement done. Whereas the knee guys, the knee replacement patients, about 20% of them said that we cannot forget the fact that we have a knee replacement done. So it's not all that natural. People need to understand that you might call both of them joints in the body, but one is a mule, the other is a bloody horse. They might look a little bit similar, but they are different animals. You can't expect a mule to, run the same way as a horse does. So let's now understand and examine, has it helped achieve this quest for the Holy Grail, which is the forgotten knee? Let's see what the world literature has to say. The databases searched are these. These are the meta-analysis and systematic review, all put together. Almost 6,800 papers on kinematic alignment and mechanical alignment issues, not just on robotics. Robotics is incidental to the fact that kinematic alignment and its variants have suddenly been brought forth as the real solution to this 20% forgotten knee. All right. So the kinematic alignment related papers, 6,800, just 6 papers out of these were found to be eligible for a worthwhile Cochrane analysis. And of these 6, 4 randomized controlled trials showed only marginal functional benefits and functional, remember, not the forgotten knee, just marginal functional benefits at about 2 years, which were statistically significant. 2 of these 6 did not find any difference. And of these 4, let me tell you, 2 of them come from the originator centers of kinematic alignment philosophy. Even in these, the forgotten knee test has not been applied. Now let's see how many different factors impact the final outcome of a TKA other than component positioning and soft tissue balancing oblique dissection. Here is the list of the first 16. Then the another 30 up to 32, 48, 65. These are not chosen by me. These are the listed aspects of what influences a total knee arthroplasty in the gamut of literature that we have reposed in our databases. given this fact, 64 different factors, which Guruva himself also brought out in his own set of slides, that of this, he is labeling only the component positioning and the alignment part, which is the same as component positioning, as the influencing fact here as far as this debate is concerned. Now, given this fact, if one expects that the alteration of 2-3 degrees of alignment planes to make a perceptible difference in the final outcome of TKA as experienced by the patient in the form of a forgotten knee, then this would be the equivalent of significantly changing the audio experience of an orchestra by slightly tensioning a single string of a single upright bass in a room full of these complex music players. What childishness are we referring to here? Now let's see the evidence. The first of it, short-term prospective study. What is robotics bringing on the table? It is nothing but one tiny layer of haptics introduced over and above the computer navigation, which offers us accuracy of component placement and planning and accuracy of component placement. So let's see here. Prospective, and I am not denying the fact that computer navigation brings in accuracy of planning. I have no grouse against it. The question we all have to address and understand is to value titrate. What does that tiny amount of metrics measurements is called metrics, So metrics analysis, does it bring value? Here is the study. Conclusion: robotic TKA demonstrated comparable, not better, comparable achievement to mechanical or TKA, manual TKA. Another paper, conclusion: robot-assisted TKA does not improve clinical or radiologic comparisons. Compared with conventional TKA. Another one at minimum 14 years, mean follow-up of 15 years. In younger patients, read the title. In younger, and this is Chitrantan Ranawat award-winning paper. In younger patients with end-stage knee osteoarthritis, computer-assisted, which means anything to do with accuracy of placement, versus conventional, did not improve function at 15 years. Computer-assisted, which is a surrogate indicator of anything that a robotics can do, which is about component accuracy, but placement accuracy, did not differ for function or implant survival at 15 years. Another one, the meta-analysis concluded that there is limited evidence that CAS TKA improves our functional outcomes. Another one, no difference in clinical outcomes between navigation, which means accuracy related and manual related. Australian registry data seems to indicate otherwise. However, please, anyone who understands the value of a registry data, these are limited by a lack of patient-specific outcomes. It is the lowest of evidences when you talk about science of precision. There is no randomized control trial, there is no blinding, nothing, and an inability to determine the role of confounding factors and selection bias. How the hell can we be so naive as to take registry data, whether Australian or Indian or anyone else, as a justification for something this precision-oriented argument? The trends in, and let us look at the proof of the pudding is in tasting. The trends in robotic-assisted knee arthroplasty coming from USA, the richest of the societies. The results of this study, and I am quoting them: sparse use of robotic assistance in knee arthroplasty. Less than 3%. This is a 2019 paper. Less than 3% of orthopedic surgeons in the United States and England reported the use of computer-assisted technology in TKA. 40% surgeons who had these equipment in their workplaces did not use it. Centers at which, look at the value titration I'm talking about. Centers at which 250, 150, if you are doing 250 in a year, etc., or 150 in a year, which is what vast majority of surgeons do. Not everyone is a GURAVA REDDY who does 10,000 in a year, These will, total knee arthroplasties are performed for will require a reduction in the annual revision rate of 2%, 2.5%, and 13% per year over a 20-year period for computer navigation to be cost effective. Robotics, real innovation. Now, these are not my statements. This comes from Robert Booth, Jawad Parvizi, the intellectual giants of our arthroplasty of today. With survivorship of arthroplasty approaching 98% at 10 years and 95% at 20 years, innovation must clear a very high bar. much of today's innovation is fostered by industry rather than by academia. We are not Luddites. This is not my statement, this is their statement. We are not Luddites, and we embrace innovation. Were robotics proven truly beneficial and cost effective, the rewards would be substantial. The minimal utilization of such technologies, even when available, was due to a perceived lack of efficacy of such surgical techniques. The study found that 80% of the robotic assisted TKA were being performed at teaching hospitals, not at hospitals where value titration, which means private practitioners, where value titration versus the cost was the determination of adoption of a technology. Improved long-term outcomes have yet to be seen. And lastly, gentlemen, I am now coming to my concluding slides. Metrics fixation, which means this measurement fixation, has elements of a cult. Studies that demonstrate its lack of effectiveness are either ignored or met with the assertion that even more data is required. Metric fixation, which aspires to imitate science, too often resembles faith. Look at this paper. This study reports, this is a study which is called a systematic review and meta-analysis, and it supports robotic TK. But when you look closely at the study, look at what it shows. This study reports 12 studies which showed improved robotic TK outcomes when compared to conventional TK outcomes. See how data is massaged. The total patients, this is a chart of those studies which they are taken into this particular review. Total patients were just 2,346. Forget that. Mean follow-up as short as 1 year or less. 11 different types of prostheses and 4 different types of robots. And that is what they are trying to say, a meaningful message out of a khichdi of this nature. And one more example of how the enthusiasts are trying to massage and go to extreme limits. This is coming from no less than Faris Sadar himself, the editor of J&J. In this paper, what they did was they tried to see whether a robotic methodology can reduce soft tissue injuries. All right. And look how they have structured the study. They put up a camera in the operation theater and took these standard photographs of all at different stages of this, and then have come up with we are subjected to believe that inter-observer and intra-observer, people were able to identify tissue injuries in the form of fibrillations and contusions based on photographs. All of you are extremely intelligent and experienced surgeons. Look at these photographs. These are the actual photographs I have reproduced from that study. Can any one of you tell me which of these photographs will show you a contusion and which will show you a fibrillation of a soft tissue? This is the length at which people are going to try and justify the use of robotics and some form of advantage. It is childish. Gentlemen, there are things that can be measured. There are things worth measuring, but what can be measured is not always what is worth measuring. What gets measured may have no relationship to what we really want to know, and the costs of measuring may be greater than the benefits of measuring. And that brings me to the last slide, why I am still addicted to people like Hans Christian Andersen, which are actually children's fable, because you must remember that these fables have brought a very strong, wise wisdom message to all of us. Well-known expression, the emperor has no clothes. And I am now referring to my dear friend GURAVA the emperor. This is what happens. 14-year-old Marcus III is nervous to take the throne. This is the young generation of surgeons we are talking about who have to now take the throne. Deciding that he can only gain confidence by dressing in the finest attire, read robotics. Marcus commands his royal clothes maker, read industry, makers to fashion him the most royal wardrobe, read technology. Taking advantage of Marcus's uncertainty and immaturity, a swindler, this is the fable part of it, I don't mean this in a nasty way, promises to make magic clothes that are invisible to fools, liars, and anyone you should ignore for a large and hefty price. Once you qualify that anyone who will not be able to see the fabric is a fool. So all the kingdom, people in the kingdom said that I can also see the fabric because otherwise he would have been proved to be a fool. Only Arno, the simple-hearted mop boy, can help Marcus out of this royal mess and teach him an important lesson about outward appearance. And this, why did everyone pretend? As I just said, that otherwise they would have been considered stupid or unfit for this role. Who will tell the emperor he has no clothes? My friend Guru. Who will tell you that you have no clothes? Well, me, Arno, the simple mop-headed boy. you are an emperor, no doubt. But in this one particular procession, I would say that it is a procession without any clothes. Thank you, gentlemen. Yes, Guru.
Thank you. Thank you, Bharat Bhai. That was excellent, argument with real caustic words.
Yeah, I told that.
I am known for that, man.
Just
You
1 minute.
call me because you want this figure. Otherwise, you would not be calling me.
Guruva, 1 minute rebuttal, please. Just 1 minute.
You see, the thing I told you, Bharat is a Shashi Tharoor, and every time he changes one argument, one debate, he will get Icarus, and another debate he will get Marcus, and third debate he will get somebody else from the historical perspective, because 80% of people don't know, so he will go on explaining that. The second thing, most important thing which you must have understood, Bharat believes all the literature is rubbish for his convenience. He dissects them, he makes them naked, and he doesn't even believe in the registry, conveniently. But when he gets his argument, I got some web video presentations of Bharat also here, and at some stage I'll show you. He will argue that the registry is the golden standard. But to his comfort, to convenience, he will rubbish the registry data also. So that is what Bharat is famous for. But second thing is, he is going to say 2 to 3 degrees, will it make any difference? My friend, that will make the difference. End of the day, that is my genuine belief, because the native joint has got a slope of joint. So probably that is the one which makes all the difference. 2 to 3 degrees is enough to make a rocket go into the sea rather than the sky. So the same thing we are talking about here. We got a constitutional virus, and we have got the ceiling effect as far as the proponents of the advances are concerned. So what are you going to achieve by your 3D technology? What is your thought process? I have not understood that.
So I will explain.
3 degrees valgus, you are doing the same thing.
No,
So
I'll explain to you in a moment.
virus might be the one which make all the difference, because we all got constitutional virus, especially we got the CPAC 1, where all our Indian knees are virus with a oblique joint line. So by restoring that, that is the answer probably. And we have done 5,000 knees so far, and it took me 5 years to marry the robot. And no doubt there is a halo effect, but end of the day, I would feel personally that this robot has definitely made a significant outcome improvement in the patients. But we are yet to go and make your Icarus and all the other examples out of the pavilion. It takes some more time, I do admit that. But you said you belittle that the 2 to 3 degrees. Probably, yes, that 2 to 3 degrees might make the difference. That is my thought process.
Thank you. Thank
Okay.
you. Bharat Bhai, 1 minute for you, please.
Yeah. So, Guru, first of all, I don't belittle registries. I don't think I've never mentioned that registry data is not valuable. I'm just saying that registry data cannot be taken for this type of scientific precision conclusions. Registry data is meant for large, certain type of observations, but not for the purpose that we are debating when we discuss merits and demerits of our technology like robotics in itself. Registry data, for example, will have so many different confounding factors factored into it. So please don't misinterpret when I say registry data is not valid for this particular context, in this context. Number one. Number two, I'll explain to you what that 3D thing is that we have at our hospital. Once again, as I said, I am not a Luddite. There is no doubt that navigation helps. What is navigation? Navigation is the ability to follow the process of what is known as image-based navigation systems. They segment out the images and the volumetric data of the patient's bony skeleton. Once that is available, if you want, you can have a 3D printing, and it will give you exactly with the tiniest of crevices reproduced, with the osteophytes reproduced. You can have the patient's bony anatomy in your hands. We have a in-house 3D lab. We have a in-house 3D printing, engineering team, etc. So what we do is, for those patients who want it, and for those surgeons who want to do it at our hospital, that we give them the ability to do an actual rehearsal. Abraham Lincoln said that if he had 10 hours to chop down a tree, he will spend 9 hours and 40 minutes sharpening the axe, and then only 20 minutes for actually cutting the tree down. The same thing applies to all of us. If what the 3D facility at our hospital allows the surgeons to do is to print out and rehearse the different bone cuts that they want, and then they do it with their conventional methodology. There is no restriction in my hospital for anyone to put a joint line oblique at 3 degrees, apex down position. First of all, let us understand, even that CPAC diagram, see, there is another lecture which I'm going to present later in the month in Shibu, and that's about Perseus, because you like the fact that I take out these historical figures. That's going to be Perseus, the guy who chopped off Medusa's head. You know who Medusa was, the snake-headed Gorgon. Which is anyone who looked or cast an eye on Medusa petrified himself into stone. It was that frightening. For young surgeons to look today at the complexity of all these different types of alignments, without actually even having the practice and intuitive understanding of how to take a stable cut. This is Medusa's head we are offering to them. And we are leading them to believe that $1 million, hello, what happened? $1 million worth of $1 million worth of equipment is going to bring long-lasting effect for what the journey started for a forgotten knee. And we are talking now of matching conventional as our data that we are putting forth. We need to understand value, man. With the value, I am talking about value titration. I am not against I'm not belittling 2 degrees here and there. I am saying how much value does it offer? There is no evidence yet that these precision-oriented matrix fixation is offering adequate value. And that's all I'm bringing to the audience. I am not against technology.
Thank you. Thank you, Bharat bhai. Over to Indrajit da.
Yeah. What a fascinating debate. Really, am I unmuted?
Yeah. You are able to hear you.
So the whole thing, just to congratulate both the speakers, this has been one of the most enthralling debates I've heard for a long, long time. And especially on the heels of the very, very poor parliament debates that we are seeing.
Any questions, Indrajit, to both of them?
I have some questions, and the number one is the dissatisfaction rate, and this goes to both of you, really 20%?
No.
Or
yeah, Indrajit, my answer is, in fact, I answered in Coimbatore also. In my own patients, we are doing a study almost about to be published, 9,000 knee replacement patients. We just asked simply 3 questions. The dissatisfaction rate is hardly 5 to 7%, because our expectations are less. The Western guys, they want to play golf, they want to have sex the next week. Our people do not have those things. They just want to have pain-free, reasonable gait. That's all they want.
Is that with robot or without robot?
No, whatever is that. This is without robot 9,000, because we just started robot 5,000 knees. So, but the dissatisfaction rate in Indian patients is hardly, among all of us, 5 to 7%. That is my personal experience.
Bharat,
Bharat will agree.
So, Indrajit, I agree with Guru that, see, I don't ever, I'm not stupid enough to ask my patients in the OPD that, have you forgotten the fact that I have done your knee? The very fact, what I mean is, and I'm not meaning this in a nasty way to the Western surgeons, because even the Western surgeons don't ask them whether you have forgotten the knee. But there was this one particular study, I think Phil Noble did it, and that is, he just brought it out, that the knee population, unlike the hip, have this 20% residual thing, who keep on feeling that it's not their native knee that they had or what they remembered they had before the arthritic process setting. So in my practice, I don't see a high dissatisfaction rate, perhaps 5-7%, as Guru mentioned. And for that, I'm quite happy to take it in my stride, because it is my firm belief that 5-7% have too many different reasons for being dissatisfied.
Absolutely, absolutely.
So just just by putting in monetary resource to correct those 2-3 degrees is not going to solve that problem, is my firm conviction on that matter. And that's the only reason. I'm not belittling the fact that computer navigation, robotics, they bring about more accuracy in component positioning. I'm not denying that. All I'm saying is it worth the price asked for? Value. That's what I'm saying, value. The key word is value
So
titration.
if I give you the robot free, you don't mind doing that, am I right?
Yeah, so if you give me the robot free, no, it's a serious and it's a very good question, actually. Fantastic question. In fact, the moderator, I should suggest that you should ask this to us. If you give me the robot free, and if it is not going to take away too much of my time setting it up every time in the theater, yes, I will do it.
Yeah.
But that is the point I'm driving at. And that is why you find in the real life world, in a country like America, in a society like America, that only 3% surgeons, despite these many years of it being around, are using it today. And of those 3%, 80% are in teaching hospitals. So I'm presenting you with data to understand. So once in a while, GURAVA can afford, and Narendra Vaidya can afford 10 robots like different shirts he wear on different days of the week, But that's not the point. The point is, when we discuss as a community, we are talking about deciding and coming up with a titrated statement. Is this supposed to be the standard of care for for the larger fraternity?
No, we are not saying standard of care. Yeah, okay, go ahead. Mohanty.
Indrajit, next question.
Next question is that, are the robots being used as a reassurance that what you are doing is perfect or near perfect or whatever you are aiming for?
Yeah, Indrajit, as I said, I waited for 5 years before marrying the robot. So I'm in the right position to answer the question. Now I've done more than 5,000 robots. Forget about the literature, forget about the Austin registry, forget about all the things there. But between us, my own patients, I can do on the first post-op day without seeing the X-ray, who got the guys who got the robot. The first 1 week, the pain relief is tremendous. There is no doubt. After 1 week, it evens out, number one. Number two, when it comes to this knee replacement advances, we have almost reached the ceiling effect as far as other things are concerned. So the only thing that still baffles us, the only thing that has got a scientific rationale, and the only thing that might be objectively measured is the so-called non-mechanical alignment strategies. As Bharat rightly said, we are not yet completely in the clarity there, but the direction from at least teaching hospitals or the so-called billionaires and emperors like me is to go on this path, and after 15 years say that, look boys, I'm wrong, this is not going to add any more to this effect. But somebody has to do it. Otherwise, we will be dark.
Yeah. So, I agree, absolutely. Yes.
See, this is the point. We have already gone down this pathway. Computer navigation is now 15 years old.
No, don't mix up, Bharat. Computer navigation, robotics were not. Let me complete. Computer navigation, robotics, and that Korean paper 15 years are not synonymous or a surrogate markers of the kinematic or functional alignments. These alignment strategies have come recently. Now we are talking more, and as you rightly said, robotics is incidental.
So now, may I? Because this particular talk, I wanted to bring the larger perspective, so I didn't go for those slides which would convey the fallacies of anyone thinking that just by doing what they think is the right kinematic alignment for a given knee of a given patient, that they are actually hitting the pre-arthritic alignment that the soft tissue envelope was made up for. But now that you are bringing it up, I will take the next 1 minute to bring home this very, very powerful understanding and argument. You see, kinematic alignment, even the Bellemans CPAC class, Bellemans understanding of constitutional varus and McDessie's CPAC classification is only about coronal alignment. It's only the functional alignment out of all these various alignment approaches that takes into account the sagittal as well as the rotational aspects, and that too in a restricted manner. These concepts are so complex. I will bet my ass that no real occupied orthopedic surgeon who is actually doing surgical work in his clinic as a reasonably busy guy will have the time, the need, the ability, and the circumstance to try and analyze, and even the best of analysis that he attempts, when the degree of deformity and bony wear, the destruction of bony material in the given knee goes beyond 5 to 8 degrees. Now, to reconstruct it based on the estimated bone loss is pure conjecture. And this whole argument is about 2-3 degrees here and there. And you are already injecting speculation and then convincing yourself. Indrajit, when you said, you are very right. What is it that a robotic surgeon, or a surgeon, rather, I wouldn't say robotic surgeon because that is a different connotation. A surgeon who is using robotics, what is he trying to, what is he ultimately getting? He is getting a reassurance that if he has decided that this patient seems to have a 3-degree downward apex, apex down morphology as a pre-arthritic status, which he decides how, in a knee which is already 10 degrees deformed, how the hell is he deciding that this knee had a 3-degree joint line obliquity pre-arthritic status, which is what the soft tissue envelope is for? By pure faith, by pure faith, or by God-given a sudden inspiration that these knees had 3 degrees. Then he decides he needs 3 degrees, and all that the robot does is check it for him that yes, he has got it at 3 degrees. That has nothing to do with what the patient's pre-arthritic soft tissue envelope was designed for. Well, we are being childish, man. I am not able to understand why this debate is required. I am not able to understand this. There is no argument for this. Even Stephen Howell, let aside GURAVA REDDY, Stephen Howell, look at all those original papers. Even he says that there is a guesstimate involved as far as anything going beyond mild deformities is concerned. And in India, 80% of knees are beyond the mild definition of mild deformities,
Yeah.
Yes, but robotic surgery is increasing by 8% every year. And by the end 2030, we'll have more than 700,000 of these robotics going on from the current 330,000.
From the world, right? Indrajit, in the world. You are talking about the world figures, right? Not India.
Yeah,
figures.
world figures.
So, but even if it is 700,000, out of the entire number of knee replacements that will be happening, it is still a minuscule portion, Indrajit.
Yes, about 10-11%.
Yeah, and even that, once, see, the true test of anything is time. And if robotics does deliver, I will be the first one. When GURAVA said that if he's on my next birthday, he's going to gift me a Mako. And I assure you, I'll do at least 2 or 3 Mako robots in a week, because I don't have as busy a practice as GURAVA.
On the birthday itself.
Yeah, on the birthday itself. So it's about value, man. On a serious note and on a jocular note. We are trying to give a message to a large audience here, presuming that this message will go eventually to all the younger generations who are jumping onto the robotic bandwagon without even understanding what value it provides. They have zero understanding of the complexities of what these alignments issues are, about what CPAC is, about how CPAC is only a coronal understanding, not a sagittal or a rotational ability. And let aside the soft tissue tensioning. Uski to baat hi nahi ho rahi hai. These are all bony issues we are talking about.
Gentlemen, let's hear from Dr. Malotra now, and a couple of questions from his side also.
Thank you very much. Let me first summarize what I think. It has really been a very interesting debate, and I congratulate both the speakers. And as a moderator, I think I have to have a moderate stance. So what I would like to quickly summarize is what I think is the flaw in vehemently supporting robot and vehemently opposing robot. So starting with the first thing, we talked about the constitutional alignment. So is it the same constitutional alignment which led to the arthritis? So is that what we want to restore?
Exactly.
So I have never understood this concept. So you are talking about restoring the alignment in the patient who was normal with that alignment and eventually developed arthritis. So that is my first reservation. The second reservation is that, very often we start kinematic alignment and then we surrender that it has got limitations. So let's not do it. Let's do reverse or inverse kinematic alignment. Then we say, no, we are not happy about this also. This also doesn't work. So I agree with the point that robot will help you shoot at the target every time. But I think our target may be wrong. So that is always have reservations about the robot being, pipped as something which will help you achieve accuracy, because we don't even know that our go-to parameters are correct or not. Next, the long term, there are so many studies with 10-year follow-up. They say the follow-up is not good. It's not different from non-robotic. But there are not as many long-term studies to say that robot is definitely better. And then everybody knows that, all the literature on robots is by authors who have had conflict of interest, and most of them have received money. So, I mean, I will believe much more if a originator, original surgeon, or the designer surgeon, or a neutral user reports on the benefits of robot than the one who has purchased. So, for example, without offending my very dear friend, you see, today you say robot is better. But then when I say, robot, the CT-based robots are better than non-CT robot, or non-CT based robots are better than CT, then suddenly that conflict of interest arises there, and then you're down from proving that robots are better to conventional, you are proving that the CT-based robots are better than non-CT-based. So that is an example of where marketing is driving. Because and then if, see, Dr. Ranawat says, nobody says that my child is mentally retarded. Nobody says that. So if I have purchased a robot, it's very unlikely that I'll say that I was a very stupid person. I bought the robot and now it is not working, so I'm going to throw it away. I know of cases where people keep robot and don't do robotic. I know of cases where people charge patient for bilateral robot, do one side and give incisions and don't even put the pins and close it. So what is it that we are trying to do? And next thing is that if you really want to recover money from robot, 50% of your surgery should be robotic. 50%, it's only then it is cost effective. And then trust me, Dr. Modi, even if he gives you a robot free of cost, don't take it, because there is the cost of disposables with every case. And there is an OT time associated with it. So here we are definitely responding to a certain group. I get everyday patients who say, I want robotic, and I do it. So I do it. And then let me also tell you, I asked Rami Surial. I said, do you believe in robotics? He said, I work in 2 hospitals. One has robot. There I operate robotic. One other one doesn't have robot. I don't do robotic there. So I said, how do you decide? He said, whenever patient wants and is prepared to pay for it, I do it. So I said, there's no difference. He says, no difference. So I said, what about the release? So they have done a study where they looked at patients who had releases and the patients who did not have releases, and there was no difference in the pain. So it's actually many times our observations are biased. Having said that, let me come to the other side. The other side is the robotics has a lot of advantages, but we are promoting the wrong advantages. We are saying it's more accurate, than somebody gets up and says, now what your alignment goals are wrong. So you are shooting at the wrong target. So what we can achieve with robot, of course, is, the surgeon's physical fitness, surgeon's mental fitness, the ergonomic considerations, which have been proven that using a robot, it puts less mental stress on you, less physical stress on you. For example, a normal total hip needs 300, on an average, 300 hammer shots with the mallet. And you can reduce those, and 45% orthopedic surgeons have shoulder problem or the upper limb problem. So we actually have not thought that we can reduce inventory, we can increase the physical and mental effort, comfort of the surgeon. And they are to give us one day that if Dr. Mohanty has 3 degrees of varus with the 2 degree joint line obliquity with a CPAC type 1, this is the best alignment for him, with which we have seen over a follow-up that the patients have best forgotten joint score. So we are, like Dr. GURAVA said, if we don't use it, we won't know it. The first thing I say when I talk about robotics, my mentor taught me, never criticize or endorse anything which you haven't done yourself. So I know, I agree with it that the patients who had robotic surgery, when they came to me for the second knee and the robot which I had borrowed had been taken away and was not available, they were disappointed. And those who had one surgery done by robot wanted it. May be patient factor, patient demand. That's why it is increasingly being accepted. But for technology to be widespread accepted and to go to the last person who's in the country who's operating, it has to be affordable, accessible, available. And these are not the final version. The improved versions will come. They'll be even more expensive. So by the time they become affordable, they'll be like iPhone. Old iPhone is cheaper. And then they come with an improved version and that's more expensive. So that is why the widespread adaptation is not going to happen. But it has a lot of advantages. I used to think and say that robot is a great education instrument, a great teaching instrument. And now there's a study where only 29% of the trainees thought that robot made it understand knee replacement better. 21 said it made it worse. And the rest said we are confused and we now think that we can't even do a conventional because we have learned robot, but we can't do it. And remember, it's like navigation. If it breaks down halfway when you are driving, unless you know the way to your destination, you will be lost. So what if the pin becomes loose during surgery? What if the robot hangs? It happens. If for a technical glitch, so you can't take away conventional teaching from the students, because if they are totally reliant on technology, if the technology fails, they'll also fail. So those are some of my observations. And I think we need more long-term studies by people who are unbiased. That's one thing. We have seen that probably the scores, the satisfaction, the forgotten joint score, all those things are still not in favor of one or other. That is also true. And we also know that the pain relief, if any, is short-lived, that everybody says. But we have to look at the application of technology for a much larger picture. And I think robots are here to stay. I don't think they'll become a routine for use of everybody. I don't think everybody will buy a robot before you start doing joint replacement anywhere in the world. And I don't think anybody who's using robot is using 50% of it for his cases, which is the number you need to do for being cost effective. So it's all we are doing partly, and we are giving our opinion based on, not what is recommended, the minimum number which you should be doing. So if you have a robot, if you are convinced that it is good for everybody, you should do it for everybody. Don't you think so?
We do around 60% of our robotics.
So that's a good number, sir. You are an ideal robotic surgeon. But let me tell you, very few people are doing even more than 20%. And I also hinted that people are even indulging in unethical things just to charge the patient more. They don't want to spend on the time on 2 robotic surgeries. So when I told Dr. Bharat that it's the disposables, but it is the OT time also. No, I can do 15 cases non-robotic. So I'll not be able to do more than 6 or 7.
No, Rajesh, let me counter that again. Once you with your experience with the 20 joints, the learning curve, you become time neutral. In fact, we are going to publish a paper. There is no rocket science in that. We do
maybe initially,
initial only 20 knees. The learning curve is 20 knees. After that, you become time neutral. After that, you become time positive. I'm telling that our robotic skin to skin is a maximum 1 hour.
It's not even 20, it's 7 to 20.
Yeah.
But listen to me how it costs OT time. You can't have a robot in every OT. Even you can't have, sir. But when I am a high volume surgeon, I put up 4 cases in 4 OTs. And you can't do that with a robot. So I implant one, I go to the next one. The wound closure is done by my team. Can you do that with the robot? Till one is finished, you can't do that. You can't keep on moving your robot one theater to other. So if you are really talking about high volume surgeons, sir, it taxes your time.
Rajesh, see, the moment you do the trial implants, you can move the robot to the next one. So you don't need to implant and wait for the robot.
It's not the same, sir. You know that you...
Guruva, I have a question. After cementing, you don't check again the alignment and all?
No need at all.
Because in manually when you do...
No need at all. That's what the accuracy is so good. And this is, I'm telling you, out of 5,000 to 6,000 knee replacements, exposure and experience, once you do the trial and once you are 19, the 4 numbers are same, you just forget about that. You don't need to bother at all.
So that's something
I have not done single one wrong.
Yeah, that's what I wanted to mention, Dr. Mohanty. Unlike navigation, where even after cementing, you
Yeah.
can still check. So
But here you don't need.
what about an inexperienced surgeon who doesn't hammer it? So we do navigation also, we do robotic also. There is no robotic system which allows you to check the alignment after cementing. Number one. Number two, when you do navigation, you don't remove the pins till everything is attended. Once in a while, you see that what was in the trial was 1 degree valgus has gone to 1 degree varus, and you just hammer the implant slightly on the lateral side and it becomes neutral, and you can do that. So
Exactly.
again, that is, that is something, again, we can argue if you like, but that we are defending it because none of the robots allows you to check the alignment after cementing. That's a drawback over navigation, which I think. Anyway, I rest my case, but I think I have tried to give what I think is a very unbiased and neutral view of robotics.
Exactly. INDRAJIT, you have any other questions?
No robotics for the patella.
Sorry?
There are no robotics available for the patella.
Patella, yeah, that's the pertinent
Right,
point. Of course,
let me
now GURAVA doesn't replace any patella.
I
So for him, it is not required at all.
I published a paper in the last 2 months, 6,800 knees, single surgeon series, no patella resurfacement. The results are outstanding, published in the international journal. So as far as the patella resurfacement is concerned, I don't need any problem with it.
So Subhranshu,
Yeah.
may I comment on that patella? I think this is a very relevant thing for all of us. If we look
just
up,
quick comment, Bharat, we are running short of time.
I agree. So if we look at the literature about what is the highest cause of revisiting operated TK, then it's the anterior compartment, the patella. 50% of revisions, if revisions are defined as reoperation after the first surgery, not necessarily the full taking out of the joint, etc. But if revisiting the TK, primary TK is considered to be a revision, then 50%, the highest number is because of patellofemoral issues.
That is a Western literature, my friend, Bharat Modi. How many times you revisited? None. How many times?
No, एक minute.
None.
Guru, there's a
point. On Western literature, that is very different.
Fair enough. So, but let me complete the point. So now what happens is when you adopt, whether it's robotics or navigation or whatever, when you adopt the kinematic alignment, even with your conventional thing, if you adopt the kinematic alignment philosophy, by definition, because you understand this, gentlemen, and this I'll conclude and rest my case here, it is, we are trying to arrogate, and that's where that Icarus dream lecture of mine, that Guru alluded to earlier. We are trying to recreate the native knee without realizing or without taking cognizance of the fact that the native knee has individualized contours of the lower end of the femur and upper end of the tibia, which we are replacing with standardized contours. If you really want to have what is known as personalized total knee arthroplasty, then your 3D printing based customized knee implants will also have to be manufactured, gentlemen, to even think that we are coming anywhere near close to personalized knee replacements. What the hell are we talking about here?
Okay, Bharat, let us hear from ASHISH. ASHISH, as a young orthoplastic surgeon, what you have learned today, just if you can enumerate the points.
Yes, so just last, I would just like to put a question to both our speakers today. So we spoke about high volume surgeons and high volume surgeons not being able to do more than, or offering it to 50% of the patients. But see, sir, what we see in a tier 1 city is that most of the knee replacements are done by not high volume surgeons. A lot of them are done by people who are having low volumes. People, Gujaratis, are coming together, contributing and buying a robot. So there are more than like 3 instances in the city of Bombay where 5 or 6 surgeons have come together, bought a robot, parked at one place. And these are not high volume surgeons. So they are probably doing 100% of their knees robotically. So what I wanted to ask is that we have been speaking about kinematic alignment, but what if a low volume surgeon uses it to do a mechanical alignment? That is one. Secondly, there was a point which was made by juniors have no understanding about balance and alignment. So both the panelists feel that this is actually going to be a good learning tool for the juniors and the fellows to train them and make them safe surgeons They might be mediocre surgeons, but they might become safe surgeons. You know.
Yeah, Ashish, can I answer that? The
Yes, sir.
robotics, forget about the cost and forget about the value from the Gujarati perspective. A robotic is the best tool that will eliminate the Bharat MODYs from the market. In other words, a fresh MS ortho can do a joint replacement as good as Bharat MODY or as good as GURAVA REDDY. That is the beauty of technology. That is the beauty of objectification. There are no more I feel good, this feels good, this feels tight, this feels no. This is objective parameters. So any average volume surgeon, provided, as Bharat rightly said it, have a basic concepts of ligament balancing, basic concepts of tissue respect, basic concepts of knee replacement done, he can do robotic knee replacement without blinking an eyelid. The learning curve is hardly 7 to 15 knees. Point number one. So I will feel the technology will happen in the near future. It will eliminate the need of experience. It will eliminate the need of UK training. It will eliminate the need of the gray hair. A fresh MS ortho can do robotic as good as Rajesh Malhotra. Full stop. As good as hip, like Rajesh Malhotra. Okay, as simple as that. All the parameters are addressed there and they are seen there. And number two, it is definitely a good teaching tool. But having said that, if somebody goes and buys a post-MS ortho on third day because his father-in-law has given him loads of money, a robot, and start to practice, I condemn that. I agree with all the other people. You should know, you should be able to do 100 to 500 knees manually very clearly. But let me tell you, I have now got 17 surgeons trained in my institute who are certified to be the teachers. 17. Out of them, 4 people said they are doing the knee replacement with me for the last 8 years. They said their understanding of the manual knee replacement has become better after the robotics. So that also is, yeah.
May I add my bit to Ashish's query? See, Ashish, the fact that if anyone wants to adopt robotic methodology, yes, I agree. It provides that instance, that trigger point for that individual, whether young or old or whatsoever, to start looking and trying to fathom out what these various alignment approaches are. So if you want a $1 million trigger point, then yes, buy a robot just to read up on this matter. But I think whether being a Gujarati or not, if you have an iota of common sense, and if knowledge is what you thirst for, and if wisdom is what you aspire to, then you don't need a $1 million trigger point to read upon what means alignments.
Don't keep on telling 1 million, 1 million.
Just a moment.
You just reduce your surgeon's charge. You can give me
just a moment. Let me bring home this aspect. So yes, who denies that if you have a robot to play around with and to even use it, yes, it does provide you that trigger to understand these alignments, but you don't necessarily have to have a robot to go for that particular area of understanding of knee replacement as a science, number one. Number two, the fact of the matter is, which you just now said, that people are desperate. They are pooling their money together because they realize intuitively that to buy on their own. I just showed you a scientific data collection by health economists that it takes 20 years of reduced 2.5% reduction in revision rates, 20 years for a 250 joints a year practice to recover the money on that particular piece of equipment as of today. So please understand, there's nothing against the precision that robotics brings. My point for wisdom is that is it yet reached a point in terms of value titration for it to be offered as a standard of care for the vast majority of fraternity? That's all I am. And that's my concluding statement on this.
So Dr. Monty, I'll also make one comment about what Ashish said, and I may ruffle a few feathers here, but that has got two connotations. One is, it is true that it's not the high volume surgeons, but the low volume surgeons or relatively not famous or relatively unknown knee replacement surgeons who think that the robot is their shortcut to fame. Because you buy a robot and then you kick 100 cases cake and the company plasters it all around the social media, 200 robotic cases, 300 robotic cases. So somebody who's not even known to be a knee replacement surgeon suddenly becomes a famous knee replacement surgeon. So that's the shortcut, and that's why people invest money. Secondly,
Exactly.
I think I would find it very offensive that a young person who's 20, 30 years old says, I'm as good as Dr. Bharat Modi because I have got a robot. So anybody can do an operation, but only a real surgeon will know how to get out of trouble. So having a robot is not a substitute for decades and decades of experience. And that's another thing which I think the young, arrogant robot buyers must understand, because robot can make them famous. It can get them business. But I have seen so many people who watch up the technology, and the technology doesn't make you a surgeon. After all, if you don't know how to respect MCL, what will the robot do if during exposure you damage the MCL? So there is no substitute for experience here. That's, I think, my last word. So in man versus machine, man is the one who really is the master of the machine.
Thank you. Thank you. Well, gentlemen, we are running short of out of time. So just to conclude that, first thing is that what I have learned from the discussions that what literature says 20-30% of our knee replacement surgeries patients are unhappy. But in Indian scenario, what we find from the experienced surgeons that at least, just 5 to 10% might be the maximum people who are unhappy after a knee replacement surgery. Number two, robots have come, it has entered our theater, it has a footprint on our theater, and it will continue to stay there, and it is not going to be out of our theater. But having said that, what we discussed that at least as a beginner, after your qualification of post-graduation, one must learn the basic techniques of knee replacement or hip replacement first, and at least do what I would suggest 50 to 100 joints independently, so that you understand what are the nitty-gritties, so that when you adopt the robots to improve your outcome or improve your alignment or balancing, whatever you say, then you can know that where it is going wrong, so that you can correct it, adequately. Now, definitely robots have reduced soft tissue release and post-operative pain. Immediate post-operative outcome is better compared to manual surgery, maybe pain control in terms of pain control or tissue trauma. But long term, if you see 3 months, 6 months down the line, the results are all same. There is not much of a difference between an experienced surgeon and a robot assisted surgery. However, at present, whatever papers, whatever we are seeing the published or whatever being spoken is from the authors or those who are designer surgeons or those who have robots in their theater. They are proponents of the robot, but having those who are experienced surgeons who have done thousands of joints, they're still seeing that how it will improve our outcome. I thank you for a patient hearing today. And I was just seeing that it is east, west, north, south, first onwards from 4 different directions of the country, 4 different regions of the country, they were expressing their outcome, and it is really national. Today's webinar is really national, and we all are together today when our independence is approaching very close. Thank you very much for joining here today, and thank you all the viewers for being here. And we can continue the discussion, and another 2 weeks time we will come out with another controversial topic in some other branch of the orthopedics. Thank you, Dr. GURAVA Reddy. Thank you, Bharat Bhai. Thank you, Dr. Malotra. Thank you, INDRAJIT, and thank you, ASHISH and GAUTAM, for being there. And finally, thank you, OrthoTV, Dr. Ashok, Shyam, Dr. Neeraj, Bijlani, and Poonam for being there. Thank you. We close the session now.
Thank you, Dr. Mohanty, for inviting. Thanks a lot.
Great pleasure.
Good night. Good
Can
night.
you stop live streaming? Poonam, you have stopped?
Sir, can I stop?
Yeah, please.
Yes,
Okay,
please.
sir.
Please.